This PowerPoint goes through the second half of Chapter 2. There are more than 5 or 6 slides, but for the most part, they're pretty cut and dry. If you guys have any questions, please let me know. Your book continues to talk about negative and positive pressure ventilators. We talked about this last semester, but just to review, negative pressure ventilators work by opening up the alveoli, so to speak. As you can see the picture on the left, it's sucking out the atmospheric air, which opens up the alveoli, and then air flows into the lungs. And then the picture on the right shows positive pressure ventilation, in which air is simply being pushed into the lungs, forcing air into the alveoli in that manner. Your book talks about open and closed loop ventilators. For you guys, pretty much everything's going to be closed loop, meaning the information that goes out comes back in. You can see the trends, you can see the waveforms, you can see the return tidal volume, that kind of thing. However, there are some ventilators called open looped ventilators. You'll set a tidal volume or a pressure, you'll set a flow and oxygen, and you'll hook it up to the patient, and whatever the patient gets, But you don't really know exactly what tidal volume they're getting. You don't know exactly what PEEP they have, that kind of thing. So as far as the ventilators that you've used, the IPPB would be an open-ended ventilator. The information goes out, you set the pressure, you set the sensitivity, you set the FiO2 with air mixture or not, and then you set the patient up, and whatever the patient gets, but you don't exactly know what their tidal volume is. If there was a leak in the tubing, unless you heard it, you wouldn't know. You don't get the return values. But the closed loop ventilators will tell you what air came back from the patient, what their true PEEP is, what are their true pressures, what is their static compliance, what is their raw, that kind of thing. That's closed loop, meaning the information that goes out comes right back in. The user interface is also called the control panel. It is also called the monitor on the ventilator, but it's where you make the settings. You guys already know how to set a tidal volume based upon ideal body rate, and the rate on a ventilator is going to be anywhere from 8 to 12 based upon the patient's situation and CO2. And then you're going to set an FiO2, again based upon the patient's situation and background. And then you're also going to set a PEEP, anywhere from 5 to 40 or 50 if you need to. And based upon those things, you're going to be setting a flow, an inspiratory time, expiratory time, and IE ratio. And we'll get into those things later. But for now, just know that the user interface, also known as the control panel, is where you're going to make the settings that will hopefully make the patient get better as soon as possible. As far as internal and external parts or circuits, for the most part, all of these circuits and parts will be internally inside the ventilator. And about 20 years ago, you could take a ventilator apart, open it up, change the tubing, change some scissor clamps, change this, change that. But now when you open it up, all you see are computer chips, so that's not really possible. I'm not going to spend a lot of time on this because it's somewhat irrelevant in today's respiratory world. What you need to know is that internal are inside the vent where you can't see them, and external are circuits outside the vent where you can see them. Pure and simple. When talking about the bellows, I have to somewhat go back to 1963 when the ventilators were called MA1s or MA2s, and they worked with a bellow system. If you are watching a 1980s movie, like the movie Halloween, it has a bellows ventilator in it. It also has an IPPB in it, actually. Might have to watch that video in class. But if you're looking at a soap opera or something like that from the 1980s, again, it would have something called an MA1, which uses a bellows to ventilate the patient. It's somewhat like bagging, I guess you could say. All you're doing is pushing air through like the bellows. I can show you an example of class if you don't understand it, but there's a picture in your book that shows it pretty well. It's the figure box 2.5, if you want to look at that. This PowerPoint shows an example of a piston-driven ventilator. This is what's used in home ventilators. A lot of times they're not seen in the hospital. But as you can see on the picture, there's a wheel that goes around and round, and as it goes around, it pushes a piston forward. and that piston pushes air out through the ventilator circuit to the patient. Pretty simple. These two pictures show a flow control valve. If you look at the picture on the left, each one of those little rectangle things with the circle thing on the end, that's called a valve. So as the valve on the left-hand side goes up, air is allowed to go into that little compartment. And then the valve in the middle goes up, and then air goes through that compartment, and then the valve on the right goes up, and then air is allowed to go through that compartment and out to the patient. Again, this is flow-controlled valve. The valves go up and down either through magnets or electricity. This is one of the most comfortable types of flow patterns for the patient. It allows flow to always be going through the circuit. The patient doesn't have to really pull hard to get air. And you'll see this one a lot inside the ventilators if you ever were to look inside of one.